Good afternoon, and thank you for joining us for our Systems for Action National Coordinating Center Research and Progress webinar. Our topic today is clinical community partnerships and 211 technology to improve early childhood developmental screening and care. Our presenter is Dr. Bergen Nelson, General Pediatrician and Child Health Services Research at Virginia Commonwealth University College of Medicine. Her interests include early childhood development, screening for developmental and behavioral concerns, and promoting healthy development for children living in vulnerable circumstances. Dr. Nelson was formerly associated with the UCLA Center for Healthier Children, Families, and Communities and the David Geffen School of Medicine. Dr. Nelson, would you like to start us off?
Thank you so much. Yes, thank you. This is a wonderful opportunity, and I really appreciate being able to address everyone today. It looks like we have a big audience, and I'm excited to hear people's feedback and ideas. My name is Bergen. I'm a general pediatrician. I recently relocated back to Virginia, which is where I grew up from, UCLA. And I'd like to acknowledge our funders. We were lucky to get one of the Public Health Systems and Services Research Program awards, now called Systems for Action, as part of the new RWJF Culture of Health strategy. That grant came to an end in January 2017, and we are very pleased to be able to share with you our results. I wanted to acknowledge my other team members from UCLA, Dr. Paul Chung, who's the PI on this grant, our project manager, Lindsay Thompson, and our really wonderful research associate, Damaris Ariola Zarate, and then our really fantastic community partners, Patricia Herrera and Irina Seves from 211 Los Angeles. They are on the line and should be able to comment at the end of this presentation, as well as Ingrid Estrada, who hopefully will be able to join us as well. This was really a team effort, so we gave it the sort of pet name of Trabajando Juntos por Nuestros Niños, which means working together for our kids. And really it reflected this partnership where we all have children's best outcomes in mind and want to work together and do the best we can together. So a little clinical background. Again, I'm a primary care pediatrician, and so we look to the American Academy of Pediatrics for guidance on what is recommended preventive service. And the AAP does recommend universal developmental screening and surveillance for children age 5 and under. And that includes surveillance, which is just about asking and documenting any family developmental behavioral concerns at every well visit, and then using a structured, validated screening tool at specific visits, specifically the 9, 18, and 30-month visit, or the 24-month visit if the clinic does not have a 30-month visit, and then using an autism-specific screening tool at 18 and 24 or 30 months. The part of that statement also includes to refer promptly and connect to services when any concerns are detected. So being a clinician, I will be the first one to stand up and say we're not doing as good of a job as we should be doing in terms of getting to universal screening. Our colleagues at UCLA, Neil Halfon and Alma Guerrero, looked at national surveys of parents and asked them, did you get these assessments using very specific questions? And only 30 to 50%. Neil Halfon found 50%. Alma Guerrero found 30% 6 years later. So it was not moving in the right direction in terms of parents reporting that their young children were having a developmental assessment from their primary care provider. But there have been some recent efforts to do quality improvement, and the rates of screening have gone up in several places, and yet there are some barriers to connecting with services. So one of my Robert Wood Johnson Clinical Scholar colleagues, Manny Jimenez, did some work with families and found that they really had trouble following up with referrals to early intervention services and evaluations. And then Tracy King, who's now working at the NIH, found that clinics really don't have great ways of tracking their outcomes, knowing who followed up and who didn't, helping them do care coordination. So there's really a need for a partnership to help clinics improve. And some of the barriers that exist in clinical settings include lack of time. That's probably number one and always listed as a barrier for anything clinical. But also we just don't have as much training as we probably should in terms of the screening tools themselves. There's also the widespread use of checklists often embedded in electronic health records, which are not validated tools for the most part. More and more people are trying to get validated tools into EHRs, and that's a wonderful thing. But there are some tools, even call developmental screening that are actually not structured developmental evidence-based tools. And then once the screening actually happens, again, the screening itself may not even be the hardest part. The biggest challenge and the most time-consuming may be connecting families with services, so making referrals and then following up and doing that care coordination. So again, it was really, there was a need for a partnership and help. This was a wonderful model that Paul Chung actually noticed, got my attention to, but this idea of a leaky system, basically, that the pathway from children actually getting care with primary care providers to having outcomes through this pathway of developmental screening has lots of opportunities for loss of voltage, if you will, in each of these steps. So children have to actually get to care, they have to get a screening provided, and then they have to be referred for evaluation. For eligibility, if they are eligible, they have to actually receive services, and then those services may or may not improve outcomes. And so the idea is that this leakiness and these cracks in the system are a problem, and why there's this big gap in terms of evidence and practice. So this is the background in terms of the evidence, and each of these steps has some evidence. So there is evidence that using a developmental screening tool does improve early detection, and we know that when you do identify children earlier, we are more likely to get them connected to early intervention services. And there are definitely studies that show specific interventions that can improve outcomes, especially early developmental outcomes like speech and language or behavior, which are associated with school readiness and improved education outcomes. And then in other bigger early intervention kind of studies like Perry Preschool and Abecedarian and the Chicago Child Parent Centers, there's long-term evidence that this early investment can really improve long-term social, educational, health, and economic outcomes. But there's really no direct evidence that links developmental screening to those outcomes directly. And part of this evidence of the early intervention and early investment is about the brain's plasticity and ability to change in response to experiences, and then the effort that such change requires. And these resources are from the Center on the Developing Child from Harvard University, which is a really wonderful resource, and it shows this rapid synaptic connection in the first early years of life. And then recently, James Heckman and his colleagues did a long-term analysis. There are many such analyses, but this very recent one from 2016 showed a 13% annual rate of return on investment and a benefit-cost ratio of 6.3, mostly because of outcomes like reduced crime, higher educational attainment, and more labor force participation. So again, this link between developmental screening and these improved outcomes has not really been made, and so we hope as a research team to contribute to that. We, in our study, have been looking at this link between screening to early intervention services. We will not discuss these improved developmental outcomes today. We hope to look at these in future research. So our question with this study was really how a system of early childhood screening and care coordination might be improved through a partnership with a centralized telephone-based community service compared to usual clinical care alone. And this was part of the public health services and systems research focus of bridging public health and healthcare. So this is a very simplistic model, excuse my simplicity, but in typical usual care, children and families in the first few years of life typically would get to early intervention services through their primary care health services. They may get there on their own. They can certainly refer themselves. They may get there through a child care or preschool program, early care and education. But the majority of children in the first couple of years of life are seen by a healthcare provider, and that often is both a gateway and a barrier to some of these early intervention services. So kind of a adjusted model is, and this was the model we looked at in our proposal for this project, was thinking about 211 as a connector across these systems, basically linking children and families who could also independently be linked to all these other sectors, but they can be an active link between children and families and early interventions with community health centers, early care and education, social services, et cetera, and that information sharing in the resource directory that already existed at 211 was a real benefit that could be used by a multitude of sectors. So you might be asking at this point what 211 is, and this is there are people on the line who know more about 211 than I do, so please at the end I would be happy to hear other comments, but this was the 2016 data that showed more than 90% coverage. This is looking at landlines of folks in each state. So this is, if you take a telephone and dial the numbers 211, you should get a call center that provides health and human services, information, and referral. And so in Los Angeles County, I should say at the state level, many states have their own statewide system. So for example, in Virginia, we have a statewide 211 system, and one of our colleagues there is on the line, and I'd love to hear her voice at some point. But in California, because it's such a huge state and the counties are so large, Los Angeles County has its own county-based system. It's part of the national network. It answers about 500,000 calls a year. And those are calls for all sorts of basic needs: housing, employment, food, et cetera, child care. In 2009, a specialized second-line program was started by Patricia Herrera to do developmental screening and care coordination through 211 Los Angeles County. And this was offered to families as a free and optional service if they have a child between birth and 5, calling for any reason, were offered this free developmental screening, which they framed as a parent questionnaire to see how your child is doing for his or her age. So it's not about making a diagnosis. It's not stigmatized. It's just about answering questions about your child. And this is, I don't expect you to be able to read these letters, but they did publish the description of this initial program in the American Journal of Preventive Medicine in 2012. So I encourage you to look at that, which really describes what they did in terms of offering this screening for folks calling 211LA. And this is just a snapshot of what they found in terms of the results of their developmental risk. And as you can see, there's a lot here, but since 2009 when the program started, they've screened 12,293 kids and counting, so probably the number is even higher than now. And the number at risk for developmental delay is much higher than the national average, which is not surprising because these families are calling, of them calling for developmental concerns, but most of them calling for basic needs, basic social needs, housing, food, employment, those kinds of things. And so those things are associated with developmental behavioral risks. So we decided to partner, and I am so grateful for this partnership. It's been a wonderful, many years long friendship with Patricia and colleagues, and Irene and Maribel. And we thought this would be wonderful to try to make a very systematic and proactive connection for children in a clinic to 211 to help with the screening and care coordination that primary care providers are having so much trouble delivering. So our study is a kind of a different twist on this existing 211LA screening and care coordination program, where we decided to test it by connecting children who are already coming to a clinic with this service that was being offered at 211. So we decided to do a randomized controlled trial, and we recruited and enrolled children between ages 12 and 3.5, and that was really because we found that most children under 12 months were not having developmental behavioral concerns yet, even though the recommended screening age starts at 9 months. Many parents don't have concerns until 12 months. So we thought we'd really get this was the sweet spot for developmental assessment in terms of addressing concerns. We ended it at 3.5 because we wanted to have enough time to follow them before they started kindergarten, and we wanted to make sure there was enough time to then provide interventions before kindergarten entry. So the randomization was one-to-one randomization to equal groups using the intervention being connection to 211 plus their usual medical care, and then the control group being usual care alone. And I'll go more into detail about the actual intervention procedures, but basically the connections to 211 included conducting screening and then making referrals to all sorts of services and then doing follow-up. They also communicated back to the provider at the clinic to give the results of the screening and the care plans. And then in the control group, the expectation was that the screening, referrals, and follow-up would all be done as usual care by the clinic staff alone. So a little bit more detail about the intervention. This was really, we decided to call it a system change intervention, which was a partnership between 211 and this clinic. And I should say that the clinic that was the partner clinic, Clínica Oscar Romero, and we'll talk more about the patient population when we look at the demographics of the sample, but this is a clinic in Los Angeles, adjacent to downtown, which has a large Latino Spanish-speaking population, mostly low income. So the connection with 211 ideally happened as a warm handoff between our research associate after going through informed consent and randomization and 211. And if that warm handoff couldn't happen, then we would exchange information between the parent and the 211 care coordinator, hoping that they would connect later. And if they did connect, at whatever point they did connect, 211 conducted this online developmental screening using the PEDS online system, which is the Parental Evaluation of Developmental Status, which is basically 8 general questions about developmental behavioral concerns, and then the PEDS developmental milestones, which is 6 to 8 age-specific milestone questions, and then the MCHAT, which is the modified checklist for autism in toddlers and autism screen for children 16 months and older. Altogether, that takes about 20 minutes, 15 to 20 minutes. And the good thing about the online system is that it is scored automatically. The computer does the scoring, and it even includes a qualitative analysis of comments that the parents can put in and the care coordinator can type in, and there are keywords that are flagged to make the risk higher or lower. So based on that summary of the risk and the results, the care coordinator has a list of recommended next steps, so evaluations or referrals to services. And in this model, the 211 care coordinator actually goes ahead and makes those referrals, preferably with 3-way calls, which is another way that we kind of felt that we could capture people falling through the cracks. So instead of just giving a number, they actually called the intervention agency and started the process of referral. And then fax the care plan back to the clinic to give feedback back to the provider about the screening results and the referrals that were being made. And then finally, after that initial intervention, the care coordination was initially in the first few weeks to make sure that they connected with those referrals and that they were evaluated and started to receive services so that they were able to connect to 211 and connect to their actual services that they recommended. And then they gave at 6 months an outcome summary of that receipt of services. So did somebody actually go? Did they get evaluated? Are they receiving services back to the clinic? So just to go over the randomized trial, this is a figure that will be in our paper that's under preparation right now, but we were able to enroll and go through informed consent for 152 children between 12 and 42 months. And they were randomized to intervention and control, so 77 were in the intervention group, 75 in the control group. And in the intervention group, 75% of them actually received the intervention. They connected with 211 during the first 6 months. And then we followed up at 6 months, and the primary analyses were done at 6 months. And we had follow-up interviews with 74% of the families. I see a question in the question box. Should I answer it now? The question is, did this intervention require additional staff at the 211 call center? And the answer is no. These were additional people in the screening program. So the screening and care coordination program were specialized, dedicated developmental screening and care coordination staff at 211 that were separate from the frontline information referral specialists. So I guess the answer is yes, but this program existed, and then we kind of tapped into it for the study and used some of the grant funds to support part of their time, but the program was existing. So after that intervention and randomization and follow-up, we wanted to get a few other measures. So we looked at some parent responses to just basic experiences of primary care. We did that at baseline, 6 months, and 12 months. And then we looked at the child's medical records. We got that permission through our enrollment and informed consent process, and we did that every 3 months for the full year of follow-up. And then we did also a sample of retrospective clinic visits just to see what the clinic's behavior was before this study started, to sort of make sure we weren't seeing a Hawthorne effect or change in the provider's behavior during the study. So we looked at what the behavior was before the study started. Another question about were these Help Me Grow staff. So no, this is not, I think this is a discussion for after the presentation, but Help Me Grow is a program that has some of the common elements that we're discussing. This particular program is not part of Help Me Grow. So this is some of our baseline data. Again, we had 152 families total. That included just the child as the N, but we were talking to the parents because they're young children. Again, 77 in the intervention group, 75 in the control. We looked at basic demographics like the child's age, gender. The predominant race ethnicity was Latino, so we didn't break down the other very much. But basically more than 90% identified as Hispanic or Latino, and then about 60% identified or primarily spoke Spanish, preferred to do the interview in Spanish. The one demographic here that was a little bit concerning to us was gender, where the number of boys seemed to be higher for some reason in the intervention group and the control group, which was somewhat of a concern just because that can be associated with developmental behavioral concerns and need for intervention services, and so we do adjust for that in our final analyses. Some additional demographics. Most of the parents were born outside of the United States, had pretty low educational attainment and low income, and this pretty well reflects the sample of the clinic where we were partnering. But again, there's not a significant difference between intervention or control in this, so the randomization appeared to be pretty good. So this is looking at just a question from the parent survey about whether in the last 6 months they had had a developmental or behavioral concern about their child. And you can see that between 30 and 40% of parents across the board said yes to that on this baseline survey, and that's comparable to the national estimates actually, and no difference between the two groups. And then we actually looked at their score using the PEDS, and there was a small sample of children in the intervention group for which this data were missing initially because they did not get their the connection to 211. In the control group, we did it as a research team. Again, there's similarity across the groups, but you can see our p-value is 0.08, and that probably reflects this difference between the moderate and high risk groups, with us more high-risk kids in the control group than the intervention group. But if you combine the moderate to high, which is really the group we probably should be focused on because they are the ones that are getting all sorts of referrals, those numbers are very similar. And then we asked, we looked both at the parents' responses and the chart reviews to see whether the clinic provider had asked about developmental milestones. And you can see that they're doing a very good job of developmental surveillance. So they're asking milestone questions at many, more than 90% of well-child visits. And then we wanted to know whether the clinic provider had noted a developmental or behavioral concern during the visit, and about sort of 10 to 15%, about 13% of the time that was true, and again, no difference between the intervention and control group. So our primary result was really about referrals and services. So the primary referrals we wanted to look at were to early intervention, which is the Individuals with Disabilities Education Act Part C program. That's for children from birth to 3. And then because we did have children older than 3, we included the Early Childhood Special Education program, which is Part B of IDEA. And so those are the high-level disability services. And you can see that in that outcome, we did see a significant difference between the intervention and control group, with 31% of the intervention group getting those referrals, with only 9% of the control group getting those referrals. And that did have a significant p-value of 0.001. After that, we wanted to see sort of what that loss of voltage was across the voltage leak system. So how many were evaluated, how many were eligible, and how many were actually receiving services. And the bottom line is really who's getting services. And again, there was a big difference between the two groups in terms of intervention and control. So 16% of the intervention group by 6 months was receiving intervention services. This is early intervention or early childhood special education. Only 1%. So you can see there was even a bigger loss of voltage there in that control group. And again, that was highly significant in terms of the difference. We looked at the retrospective control group. So there were 143 children where we looked at their charts in that first 6 months, like I said, and just to make sure that that referral rate was comparable. And we can see that the control group and the retrospective control group are very close to each other. So it doesn't appear that the study itself affected the provider behavior. And so there was a next question is about what if a family changed provider during the study. So we tried to connect with the families themselves as best we could. There was changes of providers during the study. We can tell you because some of the providers left. There was a provider that went on maternity leave. There was another provider that left, and other providers that came on board, and so there was some turnover. There were also some patients that left the clinic, and we did the best we could to follow up with them even if they had left the clinic. But to be honest with you, many of our lost to follow-up patients are patients that just left the clinic or moved out of the area, and so we had trouble following up with them. Another question, can you please clarify the control group? Yeah, so we did want to look at actual screening and surveillance. So they were doing surveillance based on the electronic health record. They're using EPIC, and EPIC has milestone-specific, age-specific milestone questions during their WellChild templates, and that was happening. We saw that happening more than 90% of the time. But when we looked at the charts and asked the parents to see whether they did any kind of screening. So we used the structured questions to try to get a parent's report of screening. We also looked at the actual charts to see if there were any screening tools mentioned in providers' notes or scanned into the record. And in our control group, we did not see any. So that was basically 0%. But we did in the retrospective control see a very small percent. I think it was 4% of visits did get some developmental screening, so like an ages and stages questionnaire or an MCHAP, but certainly not universal. And then the next question is to clarify, the online screening questionnaire was completed online by the parent or 211. It was completed by 211. So the parent was on the phone, and the 211 care coordinator was speaking with the parent over the phone and entering the parent's responses into the PEDS online system. Good question. So just to move on, based on these results, we felt like this intervention seems to be helping with these voltage drops in terms of capturing families that otherwise were falling through the cracks. So there was more screening happening, more referrals for evaluations, and more services ultimately being received. The next question is, do you think that if developmental screening was control, that there would have been such a significant difference in the referral rate? That's a really good question. So we're actually planning a follow-up study where we are going to make sure that so we did the screening just to know what the developmental risk was, but we weren't making referrals based on that. But in our next study, our proposed method is actually to do screening for everyone. So that takes that out of the hands of the provider and then allows either providers to make decisions about referrals or 211. So we're really, in our second study, we will test the effectiveness of that care coordination component and not just the screening. That's a great question. And then the next question is, what did the training for screening on the 211 operator end look like? I'm going to leave that to Patricia Herrera. She has spent the last many years doing that in terms of training and quality control. It's really her expertise. But there, I know that Irene Aceves is on the line as well. She can speak to it. She was initially an information and referral specialist at 211 and then got the special training to do the developmental screening and care coordination program. So just to move on, we did look at the multivariate analyses because we wanted to adjust for some of those potential confounders, including the child's age, gender, and home language. And so if you look at the odds of getting referrals, we did logistic regressions. We're getting odds ratios. And the odds ratio associated with being referred associated with the group assignment to the intervention is 4.1. So that's 4 times the odds of getting referral if you're in the intervention group. And then 11.6 times the odds of getting receiving services associated with the intervention group, controlling for those other factors. So this is a kind of a preliminary analysis, but I'm throwing it out there just to talk about how some of our other results. We did ask parents using adapted questions from the Promoting Healthy Development survey about their experiences in primary care. And that included things like how many recommended anticipatory guidance topics are being discussed that are age appropriate, how often is the care family centered. Those are things like, does the provider really listen to you and trust you as an expert on your child? And then things like assessment of parental smoking and substance use or assessment of parental well-being. These are things that are recommended services in primary care. And the percentages of these clinics doing this is just to let you know, it's comparable. These percentages are comparable to what's known nationally. So they're doing pretty high quality care. And we saw that there was not a change. So we looked at difference in differences, which is looking at baseline to 6-month change by group. And we could see, so it's looking at the change, controlling for any difference there might have been at baseline. And the only possible effect we found here was that at 6 months, the intervention group, there was an increase in the percentage of recommended anticipatory guidance topics discussed. And that, again, is fairly preliminary. We were going to hash it out, but one speculation, we don't know what's driving that. One possibility could be that when the developmental screening and care coordination are taken care of by somebody outside, that the provider may have had more time to discuss recommended anticipatory guidance questions. So that's something we would need to dig deeper on to really know, but it's potentially promising. So because we knew that these families had developmental behavioral concerns and risks, and we had a very early, strong effect, we could see that there was potential effectiveness of the intervention, we felt ethically compelled to change our study design to a crossover study design, where at 6 months we offered the intervention to the control group, and then at 12 months we wanted to see who had connected to 211 and what was their rate in terms of intervention referrals, interventions, and services. So at 12 months, after both groups had had some opportunity to connect with 211, increased group of the intervention group, 82% from 75, and then 60% of the control group had received an intervention at 12 months. And there was still a difference, but no longer significant, between the control group and the intervention group in terms of getting a referral for evaluation and services. So 21% of the control groups that increased, and then 35% of the intervention group had a referral, and that just bordered on statistical significance. And then same thing with services, increase the control group and the intervention group, still a small difference, but no longer significant, statistically significant at 12 months once we had offered the intervention to both groups. So in conclusion, we see that this telephone-based developmental screening care coordination through 211 has the potential to increase developmental behavioral referrals and services. It does not appear to negatively affect primary care quality, may positively affect care quality, including potentially providing providers more time to discuss anticipatory guidance topics. The other thing I wanted to bring up, and we just don't have time to go over into all the results, is that in addition to the early intervention, early childhood special education, there were referrals to Head Start and Early Head Start and other early care and education. So 68% of children in the intervention group got referrals to early care and education, in addition to other things potentially, also to other social services like parenting supports, family social service supports, behavioral health for children and for parents, and family literacy. So I'm happy to discuss. There are a few more questions I'd like to tackle, but the main limitation of this, did I just pop out of audio there? Sorry. The main limitation of our pilot study was that we did it with one clinic site. And so this was a relatively small population, and as you saw demographically it's fairly homogeneous, so it would be nice to scale it up and have a more diverse sample. We are planning a larger study in Los Angeles, which will have a larger, more diverse sample and a bigger geographic spread. We also want to follow children for a longer time so that we can actually start to see developmental outcomes. And like I said, in this next study, the hope is that we will actually take away that effect of the screening and really just look at the care coordination effectiveness. But we would love to have a discussion now about what the potential is for spreading to other 211 call centers, to connecting with the Help Me Grow system, which I think there may be somebody else on the line that knows more about this, and then thinking about how different partners might have different needs for this service. So we have presented at several academic meetings, including pediatric and health services meetings. Patricia and I recently went to the Alliance of Information Referral Systems, or AIRS, which was the 211 conference where many Help Me Grow sites were in attendance and saw our presentation. And in November, I will go to Montreal to present this at the North American Primary Care Research Group, which is a family medicine conference. We have submitted a follow-up research grant proposal to the NIH to do a bigger study, and we have a manuscript under production and in preparation, and we are actively trying to network and meet with folks and try to figure out how we can spread this. Okay, a few more questions.
I think at this point we need to hold the questions so we have time for the commentary remarks, but the moderator will bring us back to that at the end.
Thank you.
Okay, thank you.
Bergen, thanks so much. Susan Dreyfus and Jacqueline Hale have agreed to provide commentary for today's presentation. Susan is the President and CEO of the Alliance for Strong Families and Communities, and Jacqueline currently serves as the Director of Programs and Community Impact for Smart Beginnings Greater Richmond. Susan, would you like to start?
Yes, I would. Thank you all very much. And Dr. Nelson, congratulations. This is really very exciting and such very timely research for our country right now. I thought it was just a beautiful study design and how this was put together, and love the fact that you're going to be doing this next wave of the study and following the children longer. A couple of things I just want to say is that, first of all, the timeliness of this with the debate that's going on in D.C. right now could not be better, as we as a nation have the conversation about essential benefits and coverage and ensuring that all children have access to EPSDT, whether they're a child living in one state versus another, as our country starts thinking about giving states more and more flexibility in their Medicaid design. I also think that what we're recognizing as a nation is that if we're going to bend that cost curve of health care, if we're truly going to have a healthier population, that simply what we're doing in primary care will not be enough, but the behavioral, socio, and economic determinants of health will really carry the day if we're indeed going to bend that cost curve and have a healthier population. And do that not just by how we interact with our higher cost, higher need populations today, but getting upstream at those at risk of becoming those populations, which clearly this study demonstrates we truly can successfully do. The other thing that I love about this is your child and family-centered approach to it. I don't, as someone that has spent most of my career in the public sector side, having had Medicaid responsibility in one state, as I think oftentimes we are not as child and family-centered as we need to be in terms of really thinking about the unique stresses of families, especially families that face multiple issues and stressors in their lives, and how we really think about their lives, how we streamline access, how we meet them where they are, and how we make sure that their feedback back into everything we do is important, including studies like this. So I thought that was wonderful. When I look at this report, though, this study, a couple of things come to mind for me. First of all, I could see how this truly has the ability to be easily replicable across the country, and this idea of creatively leveraging existing capacities in communities, especially the capacity of 211, is really intriguing just because of the efficiency of that and helping the myriad of human services capacities that we have across the country and truly getting them linked and leveraged and integrated with primary care is music to my ears. A couple of things as I think about that next wave of the study is that we are seeing a growing number of community-based organizations deep in the behavioral health space who are now embedding behavioral health specialists right in pediatricians' offices. I don't think there's ever going to be one answer to this, but I think as a larger community committed to making sure all kids succeed in our nation and can live life with great health and well-being, we're going to need many strategies. And I think this use of 211 is certainly one of those, but I think we've got to just keep recognizing there will be others as well. And one of the things we're seeing is just a growing number of our members who are those community-based human service organizations with deep behavioral health clinical expertise who are becoming embedded right in pediatricians' offices to do those screens and to do those connections. One of the things that I think studies like this also, I hope, will help us to get better at as a nation is not just the knowledge we're gaining about the children being served, but how the data that you're collecting starts to cast a lens on whether it's Los Angeles or Omaha, Nebraska, where I just was, where the data starts to give us enlightenment on where capacity is needed in our communities, where gaps certainly are in terms of access and to services and supports that families need, but also through policy, where what we're learning starts to shed light on larger systemic change that needs to happen within our communities for all families to have the opportunity to succeed. The last thing that I want to just make a comment on is the whole issue of referral relationships. And oftentimes what I loved about this that is different is I find healthcare is wanting to refer families to services, but not with the follow-up as to whether or not those services and supports were indeed received and what difference is it really making long-term. And I think the better we get at that, the better we're all going to be in terms of not resting with just a resource and referral relationship, but referral that leads to connection, coordination, and improved family well-being. And just lastly, it's parents. I love the fact that you're talking about parents, how parents are doing, and I notice those scores are clearly lower. And, you know, CMS has just allowed now that pediatricians can do a maternal depression screen and build a child's code for doing maternal depression screens in pediatricians' offices. And I think the more we can start thinking about parent well-being as part of this work, the better off the children will be who we are interested in. So congratulations. Thank you so much for doing this. The more we bring health and human services together, the better we're all going to be, and the more we can streamline and create a single system experience for families, the better off kids are going to be. So thank you.
Thank you so much.
Thanks so much, Susan. Jacque, would you like to provide some commentary?
Yes, hi. This is Jacque Hale, Director of Programs and Community Impact with Smart Beginnings Greater Richmond. And just to give a little bit of overview, we are a regional early childhood systems building initiative. So I don't provide child care, I don't do health care, I am not a parent educator, but I live and work in the systems here at a regional level. So our Richmond metropolitan area is about 1 million or so individuals. We cover 9 cities and counties, which means we have 9 different school divisions. We have 9 or so, give or take, different departments of social services, as well as different health departments, and none of those same districts have the same footprint, really. And I'm really excited that somebody like Bergen has come to our area so that we can really bring together our perspective from on the ground, what it takes to line up these different systems in early childhood, education, health, human services, because we recognize with our partners that there are evidence-based best practices within each of those systems, but there's really not a clear way to do the evidence-based best practice of connecting across those systems. So it's very, very heartening to hear the efforts that Bergen has handled with her 211. I also have the perspective of working in an organization that housed a 211 information referral center, in addition to having an early intervention specialist there. And so here's just an example of some of the kind of translating that we do from a Smart Beginning standpoint is our early childhood intervention specialist with 211, this was a couple years ago, had some funding to do training with child care centers and wanted to recreate some kind of homemade ages and stages questionnaire kits that child care staff could use, as a part of the developmental screening. So beads, books, mirrors, little things like that. Well, being an early childhood specialist from an early intervention standpoint, she wasn't up to date on what the child care licensing regulations were, however. So just in kind of this little bit of a great training opportunity to raise awareness about developmental milestones within child care centers, ended up picking supplies that were not legal for the child care center to have on the ground in an infant and toddler classroom, or for that teacher to use because they could be swallowed. So it's kind of a very simple but realistic challenge that we have when we know that all of our partners want to do the best they can in early childhood, but we speak different languages. We have different regulations and policy that we work within. And then also looking at the connection between early intervention Part C, which typically lives in community service boards, health departments, kind of the county side of government, versus Part B, which here in our area really is firmly embedded in the school systems. So again, just recognizing the referral patterns, which do work between those areas, but where are some of those data holders? For instance, do our schools, looking at their Part B students, and they have some data that could show us where to point these early intervention efforts if we ask them to say, which one of your elementary schools has the highest number of kindergarten students that's coming to school with an undiagnosed developmental delay? But that's a very specific data question to ask them versus how do we work on these referral patterns. However, that question to the schools could very much inform on-the-ground, community-level developmental screening efforts as well. So again, my role is really looking at across the systems, and I told Bergen the other day, it's like I know enough to be dangerous, right? I am a parent, but do not call me for parenting information, but I do love and value this early childhood work and work with all these great partners across the system. We've also really been excited to partner with 211 in different ways to make sure information is easier to access for parents. We host and do large public awareness campaigns around kindergarten registration for 15 school divisions in the state of Virginia, And instead of saying call Chesterfield, call this school, call that school, we work with 211 Virginia to create a single landing page. So all we have to say on the radio, all we have to say on a Facebook ad, call 211. They can give you the information that you need for your child registered. If you have a more specific question, yes, they can help you get connected. But using 211 as the great resource it is, at the same time helping to improve the connections between our education, our health, our human services partners like 211 at the same time.
Great, thanks so much, Jacque. Now we've got time for a few questions. First question, Bergen, is what did the training for screening on the 211 operator end look like? Are there any quality control or quality improvement measures there?
Yeah, I don't know if Irene or Patricia is able to be a speaker on our audio, but it would be wonderful to hear what they have to say about that. Again, Irene was initially a frontline information referral specialist and then got the specialty training, which is basically training on the PEDS online system and the system of early childhood in the community and the protocols. So Patricia and her team wrote very detailed protocols about how to address certain concerns and what to do in different situations. And so and then in addition to what they're doing and what they're trained to do, there's the existing quality control measures that happen across 211. So they do have calls recorded and listened to by a quality assurance specialty team to see if there's feedback and things like that. So again, they are really the experts on that process. I'm sorry, I may not be doing it justice, but if they're able to get on, Patricia, Irene, I would connect you to them to really go through the details on that training. There were some other really good questions. I don't know, Dr. Ingram, if you want to go through them, or if I should just go ahead and do it. Okay.
You can go ahead. Like you've got them in front of you. Go ahead.
Okay, so Omalara had some really good questions. She was very thoughtful during this presentation. So first, any qualitative data collected on what the barriers were for those that didn't connect. We do have some qualitative data. Our research associate asked about, in the parent follow-up survey, about their experiences with 211 or not, and why, if they did not connect, why not. For the most part, it was about time and just competing priorities. And these are families, again, low-income families, often immigrant families. There was just a lot going on. People moved. People had child care issues, all sorts of just sort of other things going on in life, where sort of calling, especially I think if there wasn't a strong concern, or they weren't really eager to get connected to services, they may not have seen it as a top priority. But the problem with that is that many of the families that were lost to follow-up were also ones that didn't connect, and so we don't necessarily have great detailed information, qualitative information, if we couldn't get in touch with them. But we did the best we could to try to collect that. We will hopefully be able to present some of that in our paper. I'm sorry I don't have any quotes right at my fingertips right now, but mostly it was time and competing priorities. And then she asked next a really important question about maternal depression. We did assess maternal depression, and again, I don't have the data at my fingertips. There was a substantial proportion of moms in our sample who had some mild depressive symptoms. We asked for safety reasons about any kind of active symptoms and didn't want to go there, but we did ask about whether in the last 2 weeks or in the last 6 months, and many moms were reporting maternal depression. We have not looked at the analyses in terms of likelihood of connecting and following up based on maternal depression, but that's a really great question, and we should do some sub-analyses to look at that as a factor. Also, other higher rates among immigrant and non-English speaking families. So this is a very predominantly Spanish-speaking population, highly immigrant population, but we could definitely look at the data that we do have in terms of their immigration status, their primary language at home, in terms of their successful connections. And then Jay O'Brien has a question about the economics of scaling this initiative. So this is a special program that's in Los Angeles County. So while 211 is nationwide, this developmental screening care coordination program is only in Los Angeles County. And so it's a great question about how would we scale it up. We did do that analysis, and I wish maybe Paul could talk with a bit about this, about the economies of scale. We did some analyses saying that the price per child would go down quite a bit if we did a really scaled up version. But just to get a sense of the caseload for these care coordinators, there were 3 care coordinators, and every year did screening and care coordination for about 1,000 children each, so 3,000 children total. So it seems to be about 1,000 kids per care coordinator, although if you can, we're discussing the possibility of making that more efficient by having somebody be a frontline person doing screening for everybody, and then having the second tier person doing the referrals and care coordination, which is only going to be necessary for a subset of families. So we're going to try to make this as efficient as possible, but I don't have the actual numbers beyond that. We can certainly, we're thinking about that right now.
If I can step in, this is Paul.
Yeah, please.
So it's part of our proposal that's currently under review is actually a more detailed cost analysis and cost-benefit analysis over a longer period of time with respect to this. So hopefully that will get funded, and we'll get a better sense. In terms of economies of scale, I think there are 2 ways to look at it. One is we expect that one of the economies isn't so much the economy of scale within the 211 center itself. It's actually the economy of scale across the various clinics that we're participating, since it's likely that care coordinators would essentially be able to be sort of shared across clinics and across clinic sites, and that then reduces the per clinic costs in terms of personnel that would have to be expended if they all had sort of on-site coordinators as well. So that's where a lot of the economy comes from. Patricia's actually had success in terms of transplanting some of these techniques to other regional other 211 sites in other counties, just in terms of pilot work. And so we're actually fairly optimistic that that this is something that could actually scale reasonably at a reasonably cost-efficient pace. But we, like Bergen said, we don't have the exact numbers on that.
Thank you.
Go ahead.
No, I just said the next question was just about getting a copy of the slide. So yes, we can do that, and then outcomes for our bigger study. But we are planning to study child development outcomes and school readiness. Attendance in kindergarten is a great question, but not something we had thought about. And then Laura, Irene, and Patricia are there. Are they on? Hello? We're coming up to the top of the hour. But I would like to just highlight that Laura Pravat is at 211 Virginia, and said there is a growing trend among 211s and information referral centers to begin asking the question, are we making a difference? There's also a movement growing and providing more in-depth follow-ups to our vulnerable callers. This provides a framework to do just that with a clear focus on children and families. Thank you so much.
Well, Bergen, thanks so much for your time today. And thank you all for joining us for the webinar. And here is a list of our upcoming webinars, as well as where the webinars are archived. So if there are individuals who would like to view this again, just the URL up top will take you to an archive of our webinars. Thank you so much. If you have any questions, please feel free to contact Ann Kelly at the email on your screen. Thank you.